Thank you very much, and I welcome everyone. Because I am not meeting everybody, I will give everyone the opportunity to introduce themselves first, and then I will start with myself. Yeah, and the agenda is here. Some papers are there. If you just look at it, this is more kind of an engagement and a dialogue, and it's a part of a work which certain communities and Alzheimer's Society have started as a roundtable stakeholders meeting, which we do on a regular basis. This is a little bit more special, more wider, to see how much we can go far. Yeah. So without anything, let me start myself. I'm Hussein Musa. I am. Who am I?
You are so many things.
I'm so
Start
many
with who
things.
you really are.
I'm a community link. And I have been doing quite a lot of work with Alzheimer's Society. I just celebrated my 10th anniversary with them on the 1st of April this year. And mostly I was doing voluntary job with them. That was after I had worked in the charity sector at international level. And I've been working with Save the Children, World Health Organization, United Nations Health Commission for Refugees after I retired. So I thought I could give back. And I also work with several communities, Somali communities, Turkish communities. I'm also a member of a forum now we created in Haringey, which is called a Forum for Displaced and Refugees and Migrants. So we're trying to unpack that as well. So this is part of my work. And my favorite part of the work is engagement with Alzheimer's Society. And I've been working with Alzheimer's Society because they impressed me very much. I worked with Save the Children, who was a big organization, has about 3-4 times the turnover of Alzheimer's. And while I was working there, my passion was about equality, diversity, and inclusion. And it took us, for Save the Children, 10-15 years to come up with something like a policy. But when I came to Alzheimer's, it just took about 6 months, 1 hour. The biggest resource you can ever get about, the challenge. And there have been quite heated debates, which I was part of that. And now I'm working with community engagement, and I will tell you all when I explain the agenda. Mona?
Hi everyone, my name is Mona Osman. I live in Haringey. I learned about this event through Hussein, and I work in the energy sector, but I really think that this topic is very important, and I really want to have better awareness of it, and hopefully I could contribute one way or another. Thank you.
Hi, I'm Chris. I work at the Alzheimer's Society as well. I head up the teams that deliver our dementia support services across England, Northern Ireland and Wales. I live in Cheshire actually, but I'm down in London for a couple of days, and so thanks to Shahala and Jackie who've invited me to be part of today's conversation.
Thank you so much, Chris, for being here today. I'm Shahala Abbas, as you all know. It's just so lovely to be here today, connecting the communities and the work that we've been doing. Today is about really showcasing to Chris how we've done some amazing stuff. And we couldn't have done it without the support of Jackie. Jackie will introduce herself a bit later. But it's just so lovely to see so many of our local community partners, some of our amazing stakeholders that have driven this work, not just for the Somali community, but also for the Turkish community. So I'm just really thrilled that we are focusing quite in depth in the communities that we don't normally work with, particularly in North Central London. But this work isn't just for North Central London. It is expanding, we're sharing knowledge and what we're learning from here and taking it to every part of London where we're possible. It's about the community rather than, borough, because as Londoners, we are not, restricted by our boroughs. So thank you everyone, and I'm just so honoured that Chris is spending the day with us, or half the day.
Hi, my name is Shamla. I work with the memory service and the MAC team. So a lot of the work that I do is more in the community, in patients' houses, and working with the different organisations within the community to make it a lot easier for people that are undeprived or don't necessarily know what services are available to them. So something like this is really good because it sort of connects everyone together rather than people working in their own individual little communities and not knowing what's available for them.
Which team did you say? Sorry,
The
you
MAC
said
team.
The MAC team.
Yeah, it's a multi-agency care and coordination team. So they go to people's houses. So anybody, usually over the age of 55, they work with anyone that's identified as maybe mild or moderately frail or more complex. And you do at-home assessments. You have like GP, pharmacists, OT, physios, and care coordinators, care navigators, dementia navigators. And we work, you give like a multidisciplinary approach. So when you go to someone's house, you're able to do a full in-depth assessment, and then we then refer to anybody within the team, and it allows GPs to have know like everything that is to do with that patient, but we work on what is that patient's goal, and then we try to help them achieve it, and then for them to be independent at home after our assessments are done.
Did you say you were also part of the memory service?
Yes.
Which one?
The Haringey Memory Service, yeah.
My name is Ahu. I'm from Darman. I don't know if you know about organization. We are established ourselves in 1991 in Hackney Borough, where we get our mainly funding. We just like provide different services, health advocacy, mental health, and our counselors are all BABCP credited, and also welfare advice, and also we've been a partner with Mind. We're doing a network together, and I have been working there as a senior psychological wellbeing practitioner. And apart from providing therapy, 2 years ago, we worked together with Dementia Prevention UK founder, and I co-facilitated the group with her. Initially, the group was just introduced to community the dementia and physical exercise, and the project was only for 6 weeks, but it was really successful, and like we carried, I think, like for a year. And afterwards, I became a community health champion for dementia. That's how I got lucky to meet Shuhala. And last year, by myself and alongside with the another colleague of mine, she's a informed yoga practitioner. We did like a dementia group where we also start talking about menopause, because some of the menopause symptoms can overlap with dementia, where our patient can get confused and just like say, okay, if I have a dementia or what's happening to me. So again, this project was supposed to run only 6 weeks, but again, very successful. So we extended it another 8 weeks. And afterwards, we had Shuhala as a speaker for Dementia Week, and we have like over 20 attendees, which was quite successful again. So I think I really enjoy working with our community, and I want to currently just like our patients are from like mainly Hackney, and just like we have provide therapy services in North London, because we have a family project funded by big lottery, but working alongside with the National Alzheimer's Society, our aim is actually reach all our community, because I think everyone knows what dementia is, but we want to make it accessible, not available for our communities. And hence I'm pleased to be here. And our CEO is supposed to be here as well, but he's on his annual leave, and he passed his apologies. Thank you very much. Lovely to meet you.
And you're also Dementia a Friends Ambassador.
Yeah, I mean, yes. And I have my training tomorrow.
Okay, all right, okay, yeah.
Give me 1 minute. Okay, you can start.
Lovely. My name is Graham Samuel, and I am the Community Engagement Officer at Home Instead. So it's an organization. We take care of people in their own homes. As a part of our community initiative, we just run a community cafe, just, I think it's next door, the Community Sports Center, every second and fourth Friday. We started this for adults with dementia, but we opened it for all the other adults. We organize chair-based exercises and music, and the teas and coffees as well, so every second and fourth Friday.
Hi everybody, I'm Jackie Swap. I work for Alzheimer's Society, and I'm a regional manager in London, so responsible for all the services we deliver across the city, apart from a little bit in the southwest. and work with Shahala really closely around this community engagement work and you know, prioritising where our efforts need to be.
Hi, my name's Helen Suris. I think we can say that today is my first day as a community-led volunteer. I am a Dementia Friends Ambassador. I'm an occupational therapist by background. I worked for the NHS for 35 years up until 2 weeks ago. I worked in a community mental health team and then managed the Islington Memory Service, and then went on for 8 years to work in the Dementia Clinical Network at NHS England. In the last few years I've been leading that program, and I just want to continue the work in a different setting, and all of the things that are certainly on the program are things that we're trying to promote across London. And I hope that with the links that I've built up over the years, that maybe I can facilitate this work in any way I can. So happy to chat to anyone or help anyone in this capacity. It's lovely to be here. Thank you for having me.
Good morning. My name is Abdul Dash. I work with the Somali Islington community, and I'm looking after the seniors that need hospital, whatever they go. But dementia, it got my attention when Dr. Hussein invited me here for one workshop. Sahara was there. Then I came to attention, this dementia, I didn't know. So I thought this is simple for all people. When we get older, we start forgetting. It's a part of life. But he said, no, it's not. We can diagnose, we can prevent, we can. So then the next time we went to the Alzheimer's office, we had another meeting. Then the third one was at Arsenal. Yeah, Arsenal home. We have, and this is my fourth time. Then I became old. So I started forgetting everything. I came to say, I said, listen, don't tell me that I have dementia. I'm forgetting something. Then he said, we can do something. He said, go number 100, minus 10, go on, minus 10. I started minus 10, 90, minus 10, 80, 90. Then 7, it's difficult to make that. He said, no, go number 7, minus 7. The same thing. You know, when I go in the middle, I can't continue. Then I don't know what's going to happen. But if you go to the Somali community, the elder people, my mother-in-law, she was very brilliant. But recently she doesn't know me. She said, who are you? Oh, I'm Khadija's husband. Oh. She doesn't know that. Then later on she started to come to me. No, I remember you. But we don't know whether it's dementia or something else. So we are starting now a group of us to look after that people. So many people. To only take to the hospital, help them, medication, go to the shopping. That's all we used to do. But this is a new phenomenon, even for me to understand dementia, exactly what is it.
Thanks.
Thank you so much.
Thank you very much. Thank you, everyone. So yeah, we know each other now. So as we said, this is kind of a conversation. It's not a formal meeting where somebody does presentation and all that. So it is an engagement and it is a process which was going on. So I'll ask you to put the scene of the meeting so that we know what we're talking about, right? I think the work we are talking about is, we realize 3 facts which are already proven through studies both within Alzheimer's Society and elsewhere. There is quite an extensive expertise within Alzheimer's Society in providing and giving hope, even at situations where dementia is known to be not yet curable. I say yet, and the push of Alzheimer's Society and other organizations is to go further, do more research until we get a solution to that. On the other side, there is the communities. Normally, when I talk about universal health care, I think arguably the United Kingdom has the best universal care, which means everyone has an access. it is enshrined in the United Kingdom law, the equality law. No one should be discriminated because of their age, or this color, or whatever, or religion, to have access to health care. And that's a big tool which many people don't know. And why am I saying that? Because we know that the statistics we have, there are about 70% of the people who potentially have dementia are receiving a very good, high quality care. But there are 30% who have not yet been diagnosed. Because if you are not diagnosed, you are not entitled to have the support not only you and your carers need. As Abdul was saying, he's now struggling. This came only in the last discussions. So it's only one example. Another example, another family I remember who were here as well, and they went back and they came to me. They said, we are having a problem. So I suggested them to go to a memory clinic, and when the diagnosis is made, but that they couldn't cope, and that part was a thing, and they decided to go to Mecca. They were Muslim. They said, we go to pilgrimage first, and after we exhaust all those things, maybe we will come. So these are the things which don't come together. And in my engagement with both different communities, we have quite few networks which we work with. Haringey Collaborative is a council-led company who brings together a lot of NGOs together, community-based organizations discussing wider things. And I felt that as dementia, we care about our elders, and it's a very sensitive issue, and we can use that as an entry point in highlighting the need for access to health care. And because there are a lot of underlying causes that lead to dementia. If diabetes or high blood pressure or cholesterol is managed early, you are less likely to get dementia. But those factors can do it. So we are trying to see, to use that as an entry point so that people can do something. And I'll give you a few examples of that. In the discussions we had in the start, the communities I work with, they would say to me, but 70% is good. Yes, it's good. But it would have been good, I say, if it was representative, right? You see two boroughs, Hackney and Islington. According to the statistics available, Islington has one of the highest diagnosis rate, 80 to 85, whereas Hackney is about 60, 65, and they are neighbors. So there must be something going on. And what we are saying is, and I think that's where I realized that Alzheimer's Society's inclusive policy in that sense, despite having 70%, we cannot yet celebrate. We want to find out first, who are these 30%? Because, we want to know. Unfortunately, the data being collected over a period of long time misses the 6 protected groups, the age, the sex. Mostly the ethnicity, the age, and the sex of the person are all clear. But when it comes to religion or sexuality, people prefer not to say. Therefore, we don't know, So what I would say is, 70% is good only if I know everybody's there. Only if I know the UK law is not, we are not creating inequality and institutionalizing it, So that's how the conversation started. So we try to engage with the community. What is it that one part of the situation, the communities go for the healthcare, and there are others who don't go for healthcare. And that's where we are missing out, that link. Normally when you talk about access to health, we talk about the availability of healthcare, and then we talk about how people can afford and access. And then there's this element of utilization, acceptance. People know that there is, that acceptance is missing as well. And I don't want to put the onus on the communities only, but the communities have every reason not to have their own skepticism about this thing. And I know in the discussion some people say, dementia is something bad, it hits bad and so on. So what I'm trying to do is, to bring the expertise of Alzheimer's Society and other organizations working in dementia, and the internal knowledge of the community workers, the people who work in the community. They know the knowledge, they know what triggers the people and so on. So if we bring this together, I am hoping that one day we will have a way, at least knowing people who, why some people don't come to us. And once we discover that, then we can work out strategies on how to work that. Because, this notion comes every discussion I have. Access to health, is it a right or it's a privilege? Yeah, and I think that question we have to take it very serious, because I know many people say, okay, fine, healthcare, some people, they are very fussy, they don't want to be even sick, a little headache and I go. And we are talking now, people when they have symptoms they might go, people who are quiet, dementia is not like you have fever or blood or something, it just seeps in you through other means, and I think that's where we say, we have to create that part of the demand. It has to be the right, both the constitution of NHS, more than I do, and the UK equality law has an obligation in making sure that everyone who needs help has an access. And we haven't been doing much about that side from the community, because there was a confusion whether we talk about charity. Are we doing it? Is Alzheimer doing this job because they are nice people and trying to help what they can do? That's the charity pays it, but I believe that if it's in our constitution, then there is an obligation. It's a right? And if there is a right, we have to have a claimant. The right is between two, obligation and the claimants of their entitlements. So are we doing enough in making our community to say, hey, this is your right? It's not that they're doing a favor, nobody's doing a favor. This is what it is, and we have to demand. But in order to do that, we have to open that environment where our communities are confident enough to say, yes, I'm entitled to this. And I think that conversation we haven't reached. And my dream is, in continuing this work we do, which is very good, which Jackie Shohala have organized this, a roundtable. We bring different kind of communities. When they go back, I'm sure next time when they come, they bring us more information on how to reach in that. So my discussion today, I would like to see that triangle. Is there enough health services? And I'm emphasizing that, the quality of health, it's not only for the person living with the dementia, we also help the person who cares. That's something powerful. You don't get it. Especially me, I work at international level, I work in Africa, I work in Asia, where we were reluctant to bring patients because we didn't have enough resources to provide them. And one of the most difficult ethical question I dealt with as a doctor when I was in Uganda. There was HIV, and at that time people were talking about tests. And I remember challenging the government not to do tests with the children at that time, and people say, why? No, only adults, because we realized that the moment the family finds a child is HIV positive, they will abandon. And there was quite a lot. Uganda was one of the countries that have been affected. And what we are saying was, at that time, there was not even drugs, this as the first drug that came, which was a cocktail of about 15, highly tolerable by an adult, so were not being given to the children. So if an adult is positive, we could give them counseling, we could raise their awareness, and we could even say for those who can tolerate, get that as a treatment. So this is just, I'm giving you as an example, the difference between the availability here we have and the demand driven. So my idea would be, on the discussions today I would like to hear is, how can we reach that and change the narrative from being nice people and charitable to saying, no, this is a must, and this is your entitlement, and don't use your entitlement. Yes, please.
It's really so insightful to hear that example with HIV particularly, especially in the developing world, where service, health sector, is lagging a little bit. If you compare it to our NHS, it's like so way off. I often get challenged quite a lot in different community settings. So, I've come to a lot of your sessions, I've done workshops and things. When I deliver a dementia awareness session or a dementia friend session, the first thing I get challenged with is, well, we don't have this problem back home. We don't have this problem in India, we don't have this problem in Bangladesh, we don't have this problem in Turkey, we don't have this problem in Africa. Is this a UK problem? Is this a white person disease? So I think hearing what you're saying, it kind of re-emphasizes on the fact that we have the toolkit to diagnose. We also have treatment available, so we're able to take it that step further. Whereas if you, particularly when you said about children not being diagnosed with HIV, because they'll get abandoned if, and I'm finding from my own experience, from my own heritage, so I'm Bangladeshi heritage, that people in Bangladesh who are poor people particularly, who don't have access to health, dementia doesn't really exist for them, maybe because they're not living long enough, or if they are living long enough, they are not being supported and cared for, so they're completely abandoned. So I think these challenges, we know that challenges in a developing world is different, but because we're dealing with global majority in our line of work, and particularly in London, and the missing 30% and even the 70% that we are seeing come through to referral pathways, are they representative of those global majority? We don't think they are. Having looked at some data, having looked at even our service usage, they're not as representative. So what I'm trying to say is that is a really key, important message that we need to carry forward, to say you might not see it in the global majority countries because of the way the healthcare is set up. And our healthcare, I'm not saying that's the only solution, or that's the only answer to this, but in my experience, that's the only way I've been able to combat that. And when I did answer back with, the knowledge and, what you were saying going along with that, I was able to give that response to the challenge, but sometimes frontline staff, colleagues, I was there with a dementia advisor who has so much knowledge and experience, but he didn't feel confident enough to answer that, only because he wasn't representative of the community. So I don't know what your experiences is like. Does it make a difference because you are from a global majority, or is it? I think my conversation is going to so many different things, but it all contributes to health inequality, all contributes to causing the barrier. So yeah, I mean, how has your experience been? Do you have to be from that community to be able to challenge that, or should my white counterpart be able to say exactly what Hussein is saying, that our services are different, our NHS is, we should be proud of it, it's so much better.
I'd like to pick up on some of the things you said, Hussein. So firstly, you compared Islington to Haringey, and why is that happening? So I worked in Islington for many years. There is such a variation across London with how services are delivered and how they're resourced. So you've got Camden and Islington have got teams that not only offer diagnosis, but they offer post-diagnostic interventions and long-term support. They keep those people until death, or if they go into care homes. Haringey can give a diagnosis, it takes longer, they are not as well resourced, they can't offer all the post-diagnostic interventions. So what people are saying is, what is the point of getting a diagnosis if I can't get the support after? So that's the one thing. The other thing is, I'm of Greek background. And so, of course, when I worked in Islington, my whole caseload was Greek. And they were also, in the same way as a lot of the communities here, presented late. So very often, you find them in emergency departments because there's a crisis with carers or with a person. And what they taught me was that they look after, they also all live under one household. And they said, oh, you know what, everybody gets dementia at some point. Myth we've got to bust first, that's a myth. Not everyone who gets old gets dementia. And the other thing they said is, we're going to carry on looking after them till the end. So what's the point of getting a diagnosis? The point is that, firstly, you can explain to them that when your mother is even worse than she usually is, it might actually just be a urinary tract infection, and you can go and get antibiotics from the GP instead of letting it get so bad that you end up in emergency department. It might be that you as a carer can get the support that you need. And Shahala, you and I spoke about START, and START is a carer's intervention that now is being converted to all different languages and cultures. And we need our carers to get that, because the research has shown that as long as we can keep the carers well and they can carry on looking after people at home, that then it's cost effective, because they don't end up going into care homes, because they do want to look after their people at home. So it is a lot about the variation in resources. Good news is that North Central London, the NHS, are getting together to try and get equity across all the memory services, the 5 in North Central London, so that they all operate that from referral to end of life. But there is that extra work we have to do with all of these our ethnic minority groups to get them to go for that help in the first instance.
Yeah, that's the entitlement, right?
Right.
Yes, Ramla.
Like you said, the Haringey Memory Service is now starting to move to end of care also. So they're slowly starting to roll it out, whereas before it was, say you get an MCI diagnosis, you might get like a 3-month call, 6 months, a year, and if nothing's changed, then you are discharged from the service. You sort of let go into the community, and then you might then circle back from your GP once you've then deteriorated a lot further. But there wasn't a lot of support in the community. They might like refer you to different activity clubs and things like that, but a lot of the ethnic minority people, they're not going to go to those services, and there's a lack of those services that are tailored to them. There's a, like you said, there's a less of an understanding amongst different community groups, and the example that you gave about the people in Uganda, I think that's very similar to the Somali community. They might come into the memory service and they might get a diagnosis, but then they would challenge that diagnosis and think maybe it's not as bad, and then they're left in the community. The difference with the Somali community here and the people back home, and I think it's similar to Turkish community. I've seen patients from the Turkish community said, I just want to go back to Turkey. It's a lot better. My family live close together. They have lots of people that will be able to support them. So there's a lot of those social factors. Although the NHS is a lot better, like my grandmother has dementia, she lives back home. Her sisters live within close distance to her. She has someone staying with her to help her 24/7 care. So a lot of the social factors that are caused, that have the large impact of their dementia and their risk, is also mitigated by all of these people trying to help them, which you don't have that in the UK. Your family might live in Islington, you live here, they're driving 45 minutes to you, you have falls, you don't want to go into a care home, and the level of carers to the needs is very little. So then there's that risk to the carers' burden and the burnout and them going into hospital and things like that. So all of that is mitigated. Sometimes a lot of people go home because they're less lonely and isolated there. Everyone's working, the grandkids are not around, so they're left like that. So with the carers, we see a lot of burnout with a lot of carers in the community. There's not a lot of support for carers as well. So with these lifted different community groups, there is a huge lack of understanding about what it means to have dementia, even like accepting the dementia diagnosis, and then you have the constant circling back when it becomes far greater for them to compromise or like understand the impacts of it.